been improving and have developed their sophistication in their protections, right? We've seen that. So now the shift is to, attack these smaller facilities, right? The overall risk is compounded, right? Because we've now got smaller hospitals are often connected to larger hospitals. So they're points of entry into these large treasure troves. And we need to begin to shift that sophistication in controls and security, from the urban to the rural centers to protect, healthcare, as a tapestry of service, if you will, for the entire population.
And you think about the razor thin margins that they're operating on, right? So I mean, there's always the back and forth of I'm not even getting paid enough to cover my expenses. It seems to be a little worse with the smaller rural hospitals.
Yeah, so the Medicare, Medicaid funding model for critical access, I'm not sure if this applies to all rural hospitals, but at least for critical access, which is a pretty significant portion of them, is 2% above reasonable expenses, not even actual costs. It's 2% above reasonable expenses. And, if you studied economics, 3% is like the bare minimum that you can have that allows you to reinvest in yourself. So this really magnifies, the legacy technology problem that we have. Even larger healthcare systems will hand down, and pass along older technology that they've gotten rid of that is still useful, clinically useful, and they'll pass it down to these smaller facilities within their network. And we see that over and over again, in patient monitoring systems, are the older technology that was, they may not be 1970s, technology, but there's still 1970s algorithms that are doing the patient monitoring because they're just that old. Chemistry analyzers in the lab, are often leased and managed by third parties that are just interested in keeping it operational and making it easy to get data in and out of these systems, and not necessarily protecting the transactions of all of that. And then we also have the night hawking systems, right? If it's hard to get a primary care physician into the rural community, think how hard it is to get radiologists and specialty medicine there. So they do a lot of night hawking where they're connecting and transferring information into larger systems or larger services. So they have a lot more connections that are with outside partners that create a lot of risk in just how they do the business of delivering healthcare.
Yeah, and so if it's not bad enough, let's just kind of bring this home with an example. St. Margaret's in Illinois, so small hospital, and there are so they underwent a cyber attack. Granted, they were already having struggling like most. I mean, it's this is a tough environment anyway, but then to have a cyber attack happen. Well, what happens in a cyber attack? A couple of things happen. One is there's the cost of just trying to fix everything, right? And but then there's we have to shut down certain aspects so that the malware doesn't spread. So we have to shut down systems. Now we're not delivering care. So you think about that timeline of where you're diverting to that rural community. It's a 45-minute drive to the next hospital. They're serving this. They can't serve the community, and so the patient outcomes, especially for like stroke victims, right? I mean, it's minutes, and so the impact is enormous. But then beyond that, for St. Margaret's, it was a billing issue. They couldn't get back up. They couldn't bill because they couldn't perform services, so they lost money there. But then they couldn't bill either, and so they went bankrupt. And now they're out of business. I mean, it's done. It's gone. The hospital's been wiped out. And so that problem we thought we'd only have for like maybe 2 weeks, 3 weeks, maybe a month is forever. And it's So it really gets into a quality of patient care, patient outcomes, patient safety. You know this in cyber, and we say cybersecurity is patient safety.
Right. Right. So it's interesting, and I'll be interested to see how Change Healthcare, right, the event there is going to impact small rural hospitals and independents and small clinics out in the rural communities, because they don't have the cash reserves that large organizations have that may have helped them, get through that period of time. If you think about it, between 2010 and 2021, we lost 136 rural healthcare facilities. And the Crisis in Rural Healthcare report published says that there's 600 more at risk of closing. That's 30% of the 1,796 that are currently in serving our communities. And when they close, it leaves a huge void, right? And it exacerbates, the chronic health problems, the substance abuse problems that already exists in rural communities, and so it's not just physical health; it's mental health and social services that
Where are they
all
going to
get
get their
strained.
tests? Where do they get their tests? Where are
Right,
they going to go? It's the treatments. It's not like just the stroke patient. It's just every day. It's not there.
right, right. So, as I said, it'll be interesting to watch what happens with Change Health and how that has impacted some of these lower capacity things. But one of the things, let's talk about, because one of the things that came on the heels of that, right, was congressional funding.
Mhm.
Right, we've seen some things. Senator Mark Warner, has come out with a bill, that he's put forth that says, that if we can, if it would allow for advanced and accelerated payments to providers in the event of a cybersecurity incident, right? So we'll get money there quicker, right? If they meet minimum cybersecurity standards. And this goes back to what we've been identifying with Hiccup and what HHS has put in with the CPGs, right? The cyber goals that they've put in place. So maybe talk about that a little bit, and we'll go.
Sure. And for those of you who might not have known that the Change Healthcare attack, I'm sure most of you have, but basically dealing with authorizations and payments, and there's a huge, 1,000-pound gorilla in the room that was doing all that processing, got attacked, and they initially said, well, we'll try to help with payments and float you all some money, but going to organizations and saying, here, I'll float you $100,000 when their accounts receivable is $100 million for the day. And people just didn't necessarily understand that could have a cascading effect into other critical infrastructures like finance. So this is such a much more complicated, bigger problem. But with that, that's a great segue, that there needs to be. I think government has said, okay, we've given you some time to try to figure this out, and you're not. So and the impact's getting worse. The velocity of the attacks, the risk to patient safety is going up. We've got to step in. There's got to be. We don't want to do regulations, but I think we're going to have to do something. So, kind of with that thinking. They're looking at the landscape, and the 22 versus 23 breaches, it went up slightly as far as the number of breaches, but the number of records stolen was doubled. So it's like the same amount of work, getting twice as many records is where the money is, because they're reselling those things for $500 to $1,000 a piece. So the money, they're making tons of money. They've got, as I've read, they command $8 trillion in market impact, and worldwide, the cyber hackers. And if you think about that from a GDP perspective, the only two bigger are China and the United States. I mean, so to have a small hospital or even a large hospital system trying to go up and say, okay, we're going to defend ourselves, it's almost impossible. So the government, had to step in, and with that, they I guess HHS, Andrea Palm stepped in and said, put a concept paper together and said there are 4 things they're going to do. This is back in December. So there's 4 things we're going to do. We're going to first, we're going to come out with these things called HPH CPGs, which are cybersecurity performance goals for hospitals or healthcare. And then secondly, we're going to have some incentives. And then we're going to have some more enforcement. And fourth, we're going to set up the Administration for Strategic Preparedness and Response, ASPR, within HHS to kind of be a point person to make everything easier because we're kind of, I guess, maybe a little too fragmented for all the different ways that you can get support for cyber in healthcare. So those are the 4 things that they came up with, and they've moved pretty quickly on those. I don't know. Do you have comments on those, or do you want to kind of just jump into what those things are?
So it's yeah, I'm glad to see that they're there, and I'm glad to see that they're also aligned with a lot of the work that has been already laid down, especially with the Health Sector Coordinating Council and HICCUP. You mentioned it earlier, right? That they put out they recognize that the resourcing, the capacity, the capabilities, the competencies are different in small, medium, and large facilities, right? Large organizations, and so they really come up with like those minimum security standards, right? Like, let's secure email, right? That's the single, it's like biggest, largest threat vector, right? Phishing happens through there. It's a lot of the way that the ransomwares get injected in to the organizations, right? So it's a door. Let's talk about access management, right? Let's make sure we know who's on our network, right? And what they're authorized to do when they're there. And along with that is asset management, which is your specialty there with Clarity, right? And helping to understand, what's present, how it's talking, right? How it communicates, and then identifying anomalous communications between devices or into the network, right? And then I think most importantly, we have to think about incident response, and one of my rubs with the IT security approach is often at the very micro level. It's chasing vulnerabilities, right? And when we get to healthcare, what we really need to think about is what's the impact on patient care, right? And it's not just the safety impact. Very, very important. Let's not ever forget that, right? It's not just the safety impact, because safety is usually a one-to-one instance. It's one machine, one failure, one patient at a time, right? But when we talk about cyber, it's a one-to-many, and it can have a very wide-ranging, aspect. If we think about, the NotPetya incident that Merck went through as an example, right? I mean, it was somebody changed a setting on the firewall, and within 6 minutes, 40,000 endpoints were infected. That's how fast this stuff can get through a system. And it's very difficult, to respond and be there. But we have to think about incident response. What are we going to do to continue to deliver patient care should we lose the technologies that we've become so dependent upon? We saw this in 2019 with Spring Hill Health down in Alabama, I believe, right? Where they had become dependent upon their fetal monitoring system in their OB department. And they brought in a patient, the infant went into fetal distress with an umbilical wrap, which is fairly common, right? And with the technologies we have in place, it's not an emergency situation. But when we don't have that centralized monitoring, when we don't have 24/7 eyes on the patient and the capability to monitor that, then we have to fill in that with staffing. And if that doesn't happen, there's gaps that lead to disastrous outcomes, right? And in this case, even the death of a patient. So we have to think about incident response. Not only, what can go wrong, right? How can medical devices or the technologies that we've become dependent on, whether it's the EMRs or the PAC systems for our imaging or the clinical lab information systems for getting test results, where they need to be and in the hands of the physicians that can make clinical decisions, how are we going to fill that gap when we don't have the technology that we're dependent upon? And how are we going to restore that especially in these rural places, these rural locations that don't have a lot of redundancy in place.
Yeah, you hear stories now of the physicians that are just coming out of college, and they've only learned to document in an EMR, and if the EMR goes down, it's like, oh, we're going back to paper, and they're like, what?
What's that? Right, right.
Not
So
the
there
winter.
is, right?
Yeah, do we even have paper? Do we even have paper to write on, or so there's so many uh, parts of that incident response um, and proper planning and playbooks and really thinking through that. The other thing that came to mind was the word resilience. So we are, it's in the title here, cyber resilience. And as I'm going around and helping organizations, a lot of times, people think resilience means, getting back up when you're knocked down. How fast can you get back up? And while that's partially true, that's a lot of people equate it to, okay, we've been hit with ransomware. How fast can we, get back to where we're delivering care and services? And I would offer that NIST the National Institute of Standards and Technology has a different definition. The definition says the ability to adapt, withstand, adapt, recover from a stress, condition, attack, or compromise. So it's kind of it's a spectrum where on one spectrum is I saw something early, I detected it early, and I was able to stop it before it spread and caused problems. That's resilience.
Exactly.
All the way to the other where your EMR is encrypted and you're looking for Bitcoin. So it's where in there, so that whole spectrum, the ability to be able to manage yourself and have a response, an incident response for all along that spectrum, as well as controls, compensating controls in place to help you kind of detect everything and respond to everything sooner. So I'll say that the landscape analysis, which should be in your show notes, if not, contact either Phil or myself, either on LinkedIn or our emails. Contact us, but we're happy to get you any of the documentation we're talking about. But the landscape analysis was conducted by CMS, HHS, and basically going out and gathering information from a number of different sources, CrowdStrike, Cincinnati, Chime, just a number of different areas. Forgive me for those who I'm not including, but gathered a bunch of information and said, where are we getting hit from? And the where they came down on was exactly what you were saying, Phil. Phishing emails, that was like the number one where we continue to get hit there. Although the HC3, which is the healthcare cybersecurity communications center, said that just changed, and now it's unknown. We don't know where we're being hit from, which to me says it could be medical devices, some other type of device, or the software is just laying low and the malware is waiting, and the forensics or the activity on the network has been erased so that you wouldn't be able to tell where that came from. So one of the two, anyway, phishing is the first one. The second one is internet-facing devices with known exploitable vulnerabilities. So these things that are sitting out there, the vulnerabilities are known and they're being attacked in the wild. And it sounds like, oh yeah, we should probably fix that, right? It's like, yes, but you can't find it. If you're, especially the smaller hospitals without the right tools, it's hard to even determine what devices you have, let alone which ones are internet facing and have known exploitable vulnerabilities. Third one is vendor third party risk management, which is, I believe, why change occurred, where you talked about having more remote access need into rural hospitals. So, I mean, it just goes. It's one of the top attack vectors, and rural hospitals have to expand that vector or that attack surface because of the situation they're in. And then they get in and they do privilege escalation. They get, the right type of credentials, and away they go, and they start ransomware. So that's kind of the what they discovered in the landscape analysis, attack vectors. Any comments on there was a lot I was saying there.
So yeah, there was, and I agree with all of that. 100%. It's a challenging space, right? And we really need to think about, how can we leverage the resources, right, that are available, right, either through the HSCC, through HHS. How can we amplify those and cascade them down into, the least, I'm reluctant to use the word capable, but let's say resourced locations that we have that are providing, critical stuff. I'm going to put in a plug for the healthcare, or for Health ISAC, right? We've got a group, right? We had a special interest webinar, right, about managing cybersecurity toolkit for small organizations. And it wasn't specific to healthcare, but the toolkit is there, right? And we can absolutely help manage this. So interested in that, I'll get the link out and follow up to the attendees on that, for that. The other thing that's very encouraging, right, is the budget that the president just put out for the coming year, because one of the elements in there is $500 million of incentive dollars to encourage all hospitals to invest in cybersecurity practices. And I'm really hoping that a significant portion of this will be targeting small and rural hospitals, right, that really need that kind of resourcing there to help build the infrastructure, to help give them access to the tools that are necessary, to improve the resilience, because resilience is the ability to detect early and respond quickly, right, is really what it's about. So that you minimize the blast radius of the damage to the organization as a whole, and you're able to continue to deliver on the mission of delivering patient care.
Yeah. So on that note, the White House budget, that $500 million, you're absolutely correct. It was so they came out with where I was talking about. Let me back up just a sec. So the HHS came up with those four items, the HPH CPGs, the incentives, the enforcement, and then ASPR. So on the incentives, they came out, the HPH CPGs was broken into two categories. One was called essentials, and there are 10 goals, and they are for really the rural hospitals, the underserved hospitals. Those are called essentials. And then the enhanced is a little more sophisticated, but really for all hospitals. And so in the budget, the $500 million you're talking about, as I understand, went to the enhanced. There's another $800 million that's for the essentials, which is specifically directed towards small rural hospitals. And the type of controls there are a little more basic. You've got obviously the multi-factor authentication. You've got incident response, like you were talking about, very, very, primary, mitigating known vulnerabilities for internet-facing devices, which was, the number two thing. So they're hitting number one, they're hitting number two, and then in their third party as well. So it's hitting number 1, 2, and 3 in the 10 essentials. So I have great hope. Exactly where that's going to come from. I think initially they're talking about the Medicare Trust Fund, which has some organizations a little unhappy, saying, all you're doing is taking it out of one pocket and putting it in another. We need new money coming in. So I think a lot of that still has to be ferreted out. I'm not sure if everything has been defined yet.
Right. Well, and one of the beautiful things about connectivity, right, and IT is many of us work remotely these days, so we don't actually have to live in a rural community to support a rural community. And I think a lot of the incentives and investments can be made that way, right? We can protect the edges of these facilities, right? The firewalls, we can have remote monitoring and detection and response, by not being there. The only risk is, what if they get severed? What we lose sight to that, right? That we would have if we were in-house, and local. So there's some challenges there, but there's technology capabilities that we have, including, machine learning and AI, which helps, the bad actors as much as it helps the good actors. We just have to be motivated to take advantage of it and leverage those technologies to increase our capacity, and increase our efficiencies and decrease our response times.
Yeah, totally agree. I hope that AI plays a significant role on the defensive side, but then from the attacker's perspective, they're going to be using. I heard an example the other day where someone said attacker could use AI to generate an email that was, very persuasive, very correct, tailored towards a region, but then also change it up 1,000 times so that there would be no indicator of compromise or signature on it, so that you wouldn't really know how to look for it. If you saw it one place, you wouldn't be able to
Recognize it elsewhere. Yeah.
recognize it elsewhere. So there's just a lot of crazy things that we aren't even thinking about, but I do believe AI will have a significant role in helping to increase the protection and detection for hospitals across the board.
Right. Right. Well, and these steps don't all have to cost money, right? There are a lot of government services and capabilities that are already there, and I'm thinking primarily of CISA, who received in the president's budget another 300, almost $400 million to increase cybersecurity and analytic capabilities. But one of the services they offer, and I think that's underutilized by the organizations, in particular healthcare, is the analytics tool. They can come in and assess your network framework, your perimeter, and help you identify where you need to address things, help you prioritize that, help you build a plan, so that when this funding arrives, you already know what you need to do, where that goes. So there's a lot, and these are free services that they're offering, that are absolutely underutilized, and should be, precursors to, obtaining this and setting up new things, new elements. And then I think one of the other things is we really have to talk about, we talked about it earlier, about the technology debt that we have in rural facilities, right? And I think I would like to see the government or some other mechanism come in to help overcome that, right? Whether how we can improve and upgrade, the technology that we're using to deliver rural healthcare. There were some studies years ago that excuse me one sec. I think my puppy just found the cat. So, but there was some studies that showed that keeping patients in their community, not transferring them to larger urban centers for care where they needed specialty care, but creating the telehealth capability that allowed these patients to stay in their community and within their support network, lowered the length of stays and improved the outcomes, the clinical outcomes. And so these rural hospitals really provide, and are essential to providing, very good and adequate care. And they may not have the specialties necessary, which just means that they now have to have more partnerships and more connections and more threads and tendrils, in and out of their networks that need to be managed in order to provide those higher levels of care, that a small hospital you wouldn't necessarily be expected, to see, but you can get the levels of care more equivalent to urban, trauma centers or teaching facilities, and academic healthcare.
Yeah, and I think that those services that are offered, the SRA tool, I mean, when you go and start looking for them, especially at CISA, CISA, for those of you who might not know what we're talking about, here the Cybersecurity Infrastructure and Security Agency. HHS offers some stuff. So if you go out, start looking for it, you'll find there's a lot of services and a lot of software and tools out there that are free that at least get you started. So I totally agree with you, Phil. The other thing we should probably talk about is, the third piece in the four pillars that HHS came out with on their strategy, which is enforcement. So the HPH CPGs that have come out now are voluntary currently, but every indication is, and everything that they've written, that they're not going to stay voluntary long. And so those essentials and the enhanced cybersecurity performance goals will, in some way, shape, or form, move into a requirement. And they have suggested that CMS would be involved with respect to Medicare and Medicaid. And therefore, you're into conditions of participation. And I think it was the market basket index that they were saying that they would tie it to the penalties if you're failing an audit. Or so, not all carved out yet, but you're trying to read the tea leaves here. Have you heard anything along those lines, Phil?
So no, I haven't along those, but it's not surprising, right? And one of the things, in addition to Senator Warren's element to improve and accelerate the payments for having met minimum requirements, Senators Hawley and Peters also introduced the Rural Healthcare Cybersecurity Enhancement Act, in which they're calling upon CISA, to create a comprehensive rural hospital cybersecurity workforce development strategy. So to help close the gap, in that. And so I think that's, how do we train folks in the cybersecurity measures, countermeasures, supporting, creating curricula, improving the knowledge and awareness, of just what are the new tactics and techniques. We've seen cyber actors evolve over time, as hospitals got better with backups and weren't as ready to pay ransoms. Then they came up with the multiple ransom technique. Well, if you won't pay me, I'll go to your patients and I'll ransom them. So we're seeing this change of techniques as it goes, and that's really, that's the battle that we're in, and it's a never-ending battle, because as we continue to improve, they will evolve to get there. One of my pet peeves in this whole business is the proliferation we have of victim bashing. I think the whole HIPAA piece, was originally designed back in the 70s to really protect healthcare from healthcare, right? We were not very good at protecting patient information, and we were leaking it everywhere, and we needed, some attention to be spent on that. But I think as the world has evolved, as healthcare has gotten better with managing patient health, right? Our adversaries are no longer ourselves. Our adversaries are nation states and organized crime, and APTs that are very motivated because there's a lot of money at stake here. So continuing to penalize the healthcare organization, I think, is not necessarily the most effective way to make the change. I would love to see, more of the incentive dollars get applied to proactive rather than reactive pieces here, increasing awareness. A lot of rural health are associated with larger organizations. So how do we incentivize those larger organizations to invest in their smaller, brethren and entities, to really do that, not just handing down equipment, but making sure that they've got resources available and they're managing those edges there. How do we look at the independents and understand, how do we help those folks that are really small? And it's not just, we're spending a lot of time talking about healthcare, but certainly when we talk about small healthcare, it's a lot of private organizations, small labs, physicians practices, surgery centers, diagnostic imaging centers that don't have the resources as well, don't have the staffing, and that's a place where education is going to be really important. And I think if we can, make requirements, if you want to connect to my network and be a partner with me, then having a set of minimum requirements, and then having the resources to step into that space and meet those minimum requirements is how we'll build overall sector resilience.
Yeah, I couldn't agree more. And when you say with the extortion, like the double extortion, you don't have to look very far. So I just heard today, Change Healthcare, we had mentioned before, the Change supposedly had paid $22 million in ransomware. But as it turns out, ransomware is turned into kind of it's a ransomware as a service. And so the process is being distributed, and there's lots of different specialists for different aspects of attacking you. And so Alpha V, Black Cat, was the kind of the primary that had the software that was actually used, where Ransom Hub was the delivery, the hackers that actually hacked in. And so while they charged the 22 million, Alpha V took it from them and took it all. And so Ransom Hub said, well, I'm sitting on all their data, so I'm just going to charge them again.
Right.
And so, so it's so you don't have to look far, to see that it's a never ending problem. And if you pay the ransom, all you've told them is that you'll pay the ransom. And so they're probably coming back. Give a mouse a cookie, want a glass of milk, right? And the other point I was going to make is there's a whole nother, for those who are listening and just kind of where the dead bodies are buried or where the things that you need to worry about. The OCR, Office for Civil Rights, is kind of resurrecting their risk analysis surveys that they were doing back in 2017, 2018, which for me is very similar to the activities that you need to be doing for vulnerability management with cybersecurity. You got to know where all your devices are. You need to know what's on them. And you need to be able to say, what's at risk and how am I protecting them? And we really didn't do a good job of that risk analysis back in the day when we were just protecting patient information. But now it's really kind of spilled over to patient safety. And so I see these two dovetailing together. At least organizations should be able to make them dovetail together from a risk perspective, whether it's risk to cybersecurity or risk to privacy of data. The two really could come together quite nicely. I'll also say that the Healthcare Sector Coordinating Council, Cyber Working Group, has they've put their eyes on this too and putting their shoulder to the wheel and created a new work group I think, Phil and I participate in a lot of those work groups. I'll be participating on this new one, which is underserved hospitals. So again, just another area where, uh, you know, people are trying to come together and solve for these problems. Like anything, it's a journey. It's going to take some time, but I would get started now. I would get started now. Phil's your comment about, hey, look, there's tools out there that are free. Uh, get a spreadsheet, start getting an inventory on all your devices. Whatever you have to do to get started. Don't wait till the last minute until enforcement comes out, or you wait for the funding to come through the budget. I would get started now.
I agree. It's not, yes. I mean, if you're starting now, you're late to the game, and so sooner is better. It's interesting too, because especially around the medical devices, we talk about the regulations that are there. The FDA has been granted, statutory authority in the omnibus bill, for cybersecurity of medical devices, right? But remember, medical devices generate a lot of the data that healthcare relies on for delivering care. And we send this data into unregulated applications, whether it's the EMRs, the Epics and the Cerners of the world, whether it's the PAC systems or the laboratory information systems. None of these systems are regulated and need to be monitored and thought of as the infrastructure that drives, that provides the information that healthcare is so reliant on. And that's really what we're looking to protect, is making sure that the information that we need to determine patient care, right, is there. I will say one thing, and you brought up Change Healthcare, right? They came to Health ISAC and provided the IOCs of their attack, I think within 2 days, and we were able to share that out with the community. The benefit to the community, to all of the healthcare organizations that are members, is they were now able to, put that in and protect their own infrastructure from those very same attacks, right? So that helps the organization by sharing this information early and sharing this information, immediately, builds resilience for the rest of the community as a whole, right? We like to say we've got 10,000 analysts working for you, for the 800 member organizations that belong to Health ISAC. And the larger that grows, the more effective we will be. And I see that we're coming up against time, so I'll turn it over to you to start closing this.
Well, I would just say, I think one of the mantras is in the healthcare industry, Chris Ingles said, if you're going to beat one of us, you're going to have to beat all of us. And right. That's the mentality we have to get. The bad guys have it. They're working as a team. And we just need to do a better job of that. And I think we're trying, but we got to keep pressing. And these formats are great. I really appreciate CFF for hosting us and helping to get this word out. It's a great organization to be a part of, and so is Health ISAC. A wonderful organization, lots of great information, early information, getting it so you can be resilient faster. And so I'm delighted that the government is moving forward and doing something. It'll shake out. It's things will change a little bit, but they're definitely starting to create some incentives and some requirements around this cyber hygiene. Do you have any last words, Phil?
No, just thanks to the Cyber Future Foundation for inviting me to speak on this. I think it's an important topic. Cyber is a team sport, and so let's get on board, join the team, and get this figured out.
Thank you very much for doing this with me, Phil, and enjoyed it as always.